Good afternoon and welcome to Baptist Health International's monthly medical lecture. I would like to extend warm greetings to our returning friends across Latin America and the Caribbean. This afternoon, I have the distinct pleasure of introducing Dr. Michael Gomez, neurosurgeon at minimally invasive spine surgery at Miami Neuroscience Institute, which is part of Baptist Health South Florida. His presentation will be Neurosurgery, Not Just Brains. Dr. Michael Gomez is a board-certified neurosurgeon at Miami Neuroscience Institute, which is part of Baptist Health South Florida. Dr. Gomez is the director of minimally invasive spine surgery at South Miami Hospital. He specializes in spinal surgery, including minimally invasive procedures for degenerative conditions, tumors, and spinal deformities. Dr. Gomez received his medical degree from Tulane University School of Medicine in New Orleans, Louisiana, and he completed his internship in residency at Parkland Hospital, University of Texas, Southwestern in Dallas, Texas. In addition, he received his bachelor's in science degree in chemistry from the University of Miami in Miami, Florida. Dr. Gomez joins Miami Neuroscience Institute from Premier Brain and Spine of Florida. He is a fellow of the American Association of Neurological Surgeons and member of the Congress of Neurological Surgeons, American Association of Neurological Surgeons, North American Spine Society, and Florida Neurosurgical Society. He's, of course, fluent in English and Spanish. Please, let's give a warm welcome to Dr. Michael Gomez. Dr. Gomez, thank you so much for joining us today.
It's my pleasure. Would you like me to share my screen now?
Yes, please.
All right. There you go. Am I on?
Yes, you are.
This is probably the nicest introduction I've ever received at any talk.
Well, you deserve it, Doctor. Thank you.
So I prepared a talk that is aimed at or aimed for medical students. And essentially, neurosurgery is a very broad field, and it involves the brain, the spine, as well as functional neurosurgery, so treatment of pain disorders, movement disorders, epilepsy, and we have pediatric neurosurgery as well. And then from there, it kind of becomes more and more specialized. So in the US right now, there are roughly 3,700 neurosurgeons, and half of those are already over the age of 55. So we're kind of running at a deficit. We will need more neurosurgeons in the future, and especially with the aging population needing more and more spine treatments. So since it is aimed at medical students, the goal after medical school is to land a residency, and I'll speak specifically about neurosurgery residency in the US. So typically, I think at this point, all neurosurgery residencies are 7-year programs. In the US, there are 102 programs. And most of those programs will accept, 2 to 3 residents a year. Some of them are too small to have that many. So they have 1 resident, and others even take as many as 4 or 5, depending on the volume. So the average, I guess they looked at the number of open positions and the number of applicants over the last 10 years. And on average, there are 102 programs, average of 208 positions open for residency, and an average of 324 applicants to these programs. So let's say you want to be whatever, right? You want to be a neurosurgeon, you want to be a general surgeon, you want to be a cardiologist. It's important to audition for the part, right? So you've started medical school, you've done well on all your exams, you've done well on your rotations, but right, you have to go look for a job. And in the US, we take what's called the US medical licensing exam. And so you have to do well on those exams. So essentially, at least here in the US, at the end of your 3rd year in residency, you kind of have to figure out what you want to do, and you have to start scheduling rotations so that you can get a taste of exactly what that is. So the first part, right, is scheduling your rotations. So you decide, well, I want to be a neurosurgeon, and well, you know, New York City looks like a nice place to live, so I'm going to call the program up and see if I can spend 4 weeks there, and see what the program is like. So then you go to the program. You show up. You're clean shaven, or you're well groomed. You're rested. You're ready to go. And so the best recommendation I can give you is to be present. Right, eyes and ears open, mouth shut. Um, Ask questions, smart ones. Um, we're taught early on that if you ask questions, it seems like you're interested, but there's such a thing as too many questions. And be prepared, right? It doesn't hurt to read a little bit. So if you know that you are going to be on the congestive heart failure service, well, read something about congestive heart failure, read something about the medicines. If you know you're going to do a cholecystectomy tomorrow, read about the anatomy, read about the cholecystectomy surgery, and try to figure out what questions you think they're going to ask you. So when they do ask you, you sound pretty intelligent. And then obviously, show that you're a team player. Show that you're someone that they can rely on. Be the first one there and be the last one to leave. So, this is kind of based on my experience. When I did the rotations and when I went to interview at residency programs, I always felt really intimidated. I felt like an imposter, like I didn't belong. And there were all these people around me who, they seemed like they knew who the chairman was at this place, and what this neurosurgeon at another place had published, and I didn't know any of that. And now in retrospect, right, all these people, they sound like they know what's going on, but they have no idea. And when we're there as residents, and we, our job is to choose you for our program, we can tell. Okay. And so just expect to have no clue when you arrive, right? You think you can figure things out by reading something, but you really don't know until you're there. And it's important to wait for what I call the feels, right? So maybe you spent the last 2 years of your life or 3 years of your life thinking, I want to be a cardiologist, right? And then, so you schedule your rotations in cardiology, and after 2 weeks, you realize that this is the most boring thing that you could ever do, right? You didn't get the feels, but let's say you just happened to rotate through the orthopedic surgery service, and you thought this was just the most amazing thing, and there's no way you can go on another day without, knowing that you can do this for the rest of your life. So I think wait for the feels. You'll know it when you see it. And finally, you're interviewing to be part of a team. So, when we choose people for a program, we want to know that I can rely on that person. And so that person's going to show up early. That person's going to have a pen and a paper. That person's going to be responsible. And it's somebody that you can spend, 18 hours a day with, because you will spend 18 hours a day together some days. So residency, at least neurosurgery residency in a nutshell, the first year is typically the intern year, and you're clueless. You have no idea. Your first day of residency, the nurse calls you up and says, "Doctor, the magnesium is low," and you look at her and you say, "Well, replace it." You don't know what you're doing, but every day you learn a little bit more. And then as you move along, your second and third year, you're what we call the junior residents, and you're responsible for the sickest patients in the hospital, for the patients in the ICU, the brain bleeds, the patients who require somebody at the bedside pretty much the whole day. On occasion, you get to the OR, and your chief resident kind of teaches you how to do things, but for the most part, you have to learn to take care of patients first. Then your fourth and fifth year, you get more responsibility. They trust you to do more. And then finally, your last couple years, you're the chief resident, you're less clueless. So, your junior years, they pretty much look like this. You spend most of your days in the trauma hall, taking care of patients with, terrible car accidents. They fell out of a tree, they jumped out of a building. You're taking care of patients who've had brain bleeds like this. This is the classic subarachnoid hemorrhage from a ruptured aneurysm. And unfortunately, most of your patients look like this gentleman here with, an intracranial pressure monitor hanging out of his head. He's got a cervical collar. He's in a coma, and he's got, you know, uh, a family member just standing at the bedside, rubbing his arm, just praying that he wakes up. And so, in neurosurgery, right, you're always going to be dealing with trauma, um, and and as you get further along in the program, it really does become more fulfilling, more satisfying, because now, right, you're in your fourth and fifth year. You're less clueless. Now you have someone below you, you have someone beneath you, and so you can teach them. So you learned from your chief resident when you were a first, second, and third year. Now you're teaching the person below you, and now you're hoping that what you teach them will be good enough for them to teach those coming behind you. So essentially, you're leaving behind a legacy. As you get as you move further along in the program, you get to spend more one-on-one time with the attending, with the boss, which in the beginning, they'll pay attention to you, but you're still figuring out the ropes. Once you get further along, then the attendings, truly have more of a vested interest in you, because again, you're their legacy. And then finally, as a chief resident, these are sort of your final formative moments as a physician. This is when your attending, really wants to make sure that you are polished, that you understand the procedures, and not only do you understand that you can teach the procedures, right? Because once you can teach someone to do something, you're pretty much an expert. So now you're in charge, and now it's time to look for a job or look for a fellowship spot. So, right, in neurosurgery, we talk about fellowships. So some people, in spite of finishing 7 years of residency, they decide they need more training. And so you can do a fellowship in pediatrics and complex spine surgery and cerebrovascular surgery, so aneurysms, arteriovenous malformations, things like that, and then complex tumors of the skull base. Or you can say, you know what, I have had enough. It's time for me to start making a living. So you can go into academics, essentially working at a teaching institution where you are passing on the art and the science of your practice. You can go into private practice where you set up an office and you start seeing patients and you start operating, and that's how you make a living. Or you can do what's now called privatemics, which essentially it's what we have here at Baptist Health South Florida, which is a combination of a private facility in combination with an academic purpose. So essentially, teaching residents, forming surgeons, and eventually here we'd like to start a neurosurgery residency program and at least have fellows for spine surgery and brain tumor surgery. So my experience, well, I'm from Miami, and so after being gone 11 years, I came back to Miami and I started private practice. And I started with general neurosurgery. I was doing a lot of emergency room call, doing a lot of trauma, and then gradually I focused on spine surgery. And most surgeons will tell you that probably when they recently finished surgery, their first year out in practice, the best they'll ever be as far as being a well-rounded jack of all trades is immediately after training. But slowly you start to do certain things less and less. You start to do certain things more and more. And that's how we wind up super specialized. So my specialty in spine surgery, somebody else may specialize in brain tumor surgery, and so on and so forth. So, right, in the beginning, I operated everything. And then I started doing less and less brain tumors, less and less brain surgery, and realized that 95% of my practice had become spine surgery. So I decided to no longer be a jack of all trades and master of none, and truly become an expert in spine surgery. So spine surgery involves the treatment of herniated discs, of spinal stenosis, of spinal deformity, of vertebral tumors, so metastatic tumors, and spinal cord tumors, as well as the obvious trauma, so fractures and such. So when it's time for you to go out and find a job and figure out what you want to do, you have to find the cracks, right? So if if you want to be a spine surgeon, say, you don't want to go in a community where there are 70 spine surgeons, because you know what, you're going to go hungry. So is the market saturated? That's the first thing you have to ask yourself. Second, is the market open, right? So is there any place where I can stick my foot in the door and find my way in? And then, is there an opportunity that no one has taken, or few people have taken? And so that is more of a statement on sort of super specializing. So, are you going to be the urologist who does everything with the robot when most urologists only do some things with the robot? Or are you going to be the minimally invasive spine surgeon? Or are you going to be the minimally invasive heart surgeon, right? Is there a crack there that people have not yet entered? So low back pain, right? Extremely common, and the literature says that 80% of people will experience back pain in their lifetime, right? That seems low to me. Most back pain is acute. It could last, days to weeks, and then some people will develop sciatica. In fact, what the literature states is only 1% of all those people who present with back pain will ever go on to have surgery. Okay, so this is a big problem. So right, there should be plenty of jobs. And so low back pain can start with a lumbar strain. So you haven't been to the gym in 2 years, and now all of a sudden you want to start doing deadlifts, or you have a disc herniation, you fall out of a tree, you fracture your spine, you develop scoliosis in your old age, or your discs degenerate, so on and so forth. So typically when there's a common problem, the market's going to be saturated. So if you decide to enter a saturated market, you need to find an uncommon solution, right? So many choose minimally invasive surgery. So I've chosen minimally invasive spine surgery as my thing, my forte, because I noticed that it was something that just wasn't being provided in the community. The same goes for practices in general surgery, urology, OBGYN. The robot right now, the Da Vinci is this very powerful tool for minimally invasive treatment of those problems. So, we've already established that minimally invasive spine surgery, or minimally invasive surgery in general, results in less blood loss, right? Less tissue damage, less post-op pain. So the recovery is quicker. Patients are back to work quicker. They're out of the hospital much quicker, and they're getting back to a healthy, happy, productive life much quicker than with traditional exposures. Unfortunately, it can be difficult at first. It has a steeper learning curve, and it requires specialized equipment, right? I've talked about the robot. For spine surgery, we need special retractors, and some people may need some additional training just so they can get enough cases under their belt to be able to do this surgery efficiently, effectively, and most importantly, safely. So, spine surgery in general, we treat anything from the base of the skull, right, from C1 all the way down to the sacrum. And so starting at the upper extent of the spine is the cervical spine, and up in this area, it's extremely common for patients to have herniated discs. So we see, over here is the patient who has a large herniated disc at C6, C7 with severe narrowing of the spinal canal and compression of the spinal cord. This, in general, it's not considered a minimally invasive spine surgery, but when we do this surgery, we don't cut any muscles, barely. And so this surgery is something that allows patients to be pain-free in a relatively short amount of time, missing minimal work, by understanding the anatomy, moving between muscles to get to the front of the spine, remove the disc, and stabilize that level. Sciatica is probably the most common thing that we see as spine surgeons, and it's a classic symptom. It causes back, buttock, and leg pain. Can have numbness and tingling, weakness. Typically, it's worse with prolonged sitting. It's worse with driving along ways. Some people get it when they're standing and they're walking too long, and it goes away when they lean forward or sit. Excuse me. And so, this is probably the most common spine condition requiring surgery. This is the kind of classic herniated disc that compresses a nerve root in the lumbar spine and causing pain going down the leg. These are a number of approaches to the spine. So this is kind of getting into the foray of minimally invasive spine surgery. So as I said, right, when you have a saturated market, you need a new solution. And so typically and traditionally, the majority of spine surgery has been performed from the back. Now, if you look at this, I mean, these muscles are enormous, right? So in traditional approaches to the spine, we have to make an incision in the midline, peel all of this muscle off of the spine, and that can be extremely painful. There's a not insignificant amount of blood loss, and you are disconnecting muscles from their natural insertions that have been there from birth. And so, now with minimally invasive techniques, we're finding a new approach to an old problem. So, when we operate on the disc, we have to go all the way around the nerves to get to the disc. And that just seems not very straightforward. So these new approaches are utilizing different corridors that allow us to directly access the disc without ever even having to touch a nerve. So, so we're describing an anterior lumbar fusion where we make a small incision in the abdomen, slide the peritoneum over, and it gives us direct access to the disc from the front. And we're able to put a large implant from the front, place, screws and plate from the front. We also have access from the side where the patient sideways and all this slides forward, and we have like direct access to the disc here by just sliding this muscle back without even cutting it. And so all this results in patients getting out of the hospital quicker, less blood loss, less tissue injury, and people are getting back to work quicker. And that's a big deal to patients, a big deal not to miss work. And it's a big deal not to miss out on life because you're still recovering from a large surgery. So this is the reason that we can do minimally invasive spine surgery, the retractors. Without these retractors, there's just no way to do the surgery. So essentially, these retractors allow us to make very small incisions at the surface, but then give us enormous exposure at the bottom of the retractor. Not only that, a lot of them have lights that come in, so we can see, we can probably see better down here with the lights than we do up here. And they result in decreased tissue injury because, we start with a thin blade and then we start sliding a series of tubes over them. And rather than cut through the muscle, they essentially push the muscle aside and then give us direct access to the anatomy that we need. So sciatica. So, this can be caused by a herniated disc. It can be caused by lumbar spondylolisthesis, and it can also be caused by, ultimately like an adult lumbar deformity. So this is just, a very common, straightforward case. 42-year-old lady with right-sided sciatica who has a fairly large disc herniation here at L5S1. Typically 85% of people who have sciatica will get better on their own, but eventually most, a lot will require some sort of surgery. So this is a good example of how helpful our retractors are. In this case, we do take a posterior approach. We do mobilize the muscle, but we do our surgery through about a 2-centimeter incision. These patients, typically go home the day of surgery. Within about a week, their immediate postoperative pain is gone or much improved. But immediately, same day as surgery, these patients have relief of their sciatica, and it's safe, right? A 1 to 3% complication rate. This is another case of a surgery that lends itself very well to minimally invasive approaches. So this is a 42-year-old female who had bilateral leg pain, worse with walking, better with laying down. And on the MRI, she's laying down on the MRI scanner, and the MRI looks perfect, right? Perfect alignment. But this disc looks a little bit dark and degenerative. So her symptoms are worse when she stands. So we did the obvious. We got her an X-ray standing, and you can see that this vertebra is slid forward quite significantly in relation to this one, right? Had we just looked at the MRI, I would have said, "Lady, I have no idea what's wrong with you." But we gave her the benefit of the doubt and got these X-rays, and we could see that she had a deformity here. So this is a patient that we performed an anterolateral lumbar interbody fusion. So essentially, we place the patient sideways. We make a small incision in the left abdomen, and that lets us get to the side of the vertebral body. We mobilize the psoas muscle. We do a complete discectomy, and then we place a large implant into the disc space that essentially activates the ligaments of the spine, pulling the vertebral body back into alignment, and then decompressing these nerve roots. And then because, right, depending on her body position, because that vertebral body was sliding back and forth, we place screws in a rod to stabilize the spine. And this is a same day surgery. So she had surgery in the morning, went home the same day, and within a week was going to the grocery store and doing her normal daily activities. And the nice thing about the surgery is had she undergone a traditional open surgery, she probably would have lost 200 to 300 cc's of blood and would have likely spent 2 nights in the hospital. And with this surgery, I think we lost maybe 20 cc's of blood. Same thing. This is a patient who's already had surgery at L5S1 and has sciatica again, and has a degenerative disc. So, this is a patient that we treated with an anterior approach to restore the disc space height and open up the holes on the sides of foramina. So we approached from the front, placed a large implant in the disc space to restore the disc space height, and we placed the plate to secure it in the front and never had to open her up back here because, right, if you have a patient who has a lot of back pain, the last thing you want to do is open somebody up from the back and disconnect the natural muscular insertions. And again, this patient, I think, spent 1 night in the hospital. We preserved her posterior muscles and were able to maintain a natural bony alignment. This is kind of one of my favorite surgeries because this is very telling of what we're dealing in medicine. So we have an aging population, and thanks to modern medical advances, people are living longer and they're living healthier. So the baby aspirin and the statins are working their magic. So now this patient had this lumbar fusion, oh, 12 years ago. And she has developed degeneration at this level over here. And the poor thing, she's 79 years old, she's healthy, but she's miserable with terrible sciatica. She's unable to walk, she's unable to stand for very long, she has to sit all day, and she enjoys spending time with her grandchildren, and she just can't do it. So with the aging population, right, we have to find a safe and effective solution, because typically these older patients, they're not going to tolerate a large open surgery with heavy blood loss and long hospitalization. So with her, we use the same approach I talked about before, coming in with a small incision on the side of the belly. And through that small incision, we're able to place this fairly large interbody spacer that restores the height of the disc space, restores the size of this foramen over here, and then we're able to place 2 screws, one above, one below, with the rod to stabilize it. Surgery took us 1 hour. We had a total of 5 cc's of blood loss, and this 79-year-old female patient, went home the next day, and I saw her 2 weeks later, and she was already playing with her grandchildren and going to the grocery store and leading a normal, happy, healthy life with minimal pain. The same sort of goes for this case. This is a 68-year-old lady who has had 3 prior lumbar spine surgeries by another surgeon, and now she had a foot drop. She's 68, she's a healthy 68, and she really enjoys traveling, but she can't because she's having so much pain. And so she's developed a scoliosis of her lumbar spine that's due to a severe degeneration of these discs. So again, we used a combined minimally invasive and open approach to correct her deformity by restoring the heights of these disc spaces and straightening out her spine and placing the hardware. And so now, this patient is now 6 months out, and she's able to go for walks with her family. She's able to go in the pool. She's able to kayak. She's able to swim. And again, she has a happy, healthy, productive life. So, when you choose a career path, one thing I've realized through experience is that you may be going into one specialty, right? General surgery, neurosurgery, cardiology, urology, OBGYN, but it's not as narrow as you think it is. And there's opportunity for specialization, subspecialization, and really finding those things, that niche that you enjoy and that you're good at. But, right, you have to get into residency first, and you have to do well in residency to get to that point. So whenever I got a new intern, when I was a resident, I would give them this pep talk. And this is basically 1, 2, 3, 4. Number 1, keep your head down and your feet moving. And next thing you know, you'll be done. Second, you will mess something up every single day, and that's okay, right? As you grow in your medical career, you will mess up less, right? And then finally, don't make the same mistake twice, okay? And try to enjoy yourself, right? Medical school can be fun, and residency can be extremely stressful, but it can also be extremely fun, and you will make friends in residency and in medical school that will last you an entire lifetime, because you develop extremely intimate relationships with all these people that you work so closely with, and you will trust these people with your life. And God forbid you need surgery or something medical in the future, those are probably the people that you will turn to for help. So that's all I have for you. Thank you very much for listening.
Thank you so much, Dr. Gomez. Thank you for the wonderful advice you provided all of us, and especially the students and the student doctors that are present today. We have about 128 participants, and I know that they will have some questions, but there is one individual that I want to acknowledge, and it's Dr. Nunez from Universidad Marcos Nunez. He is the Dean in Universidad Iberoamericana in the Dominican Republic. Thank you so much for being with us, Dr. Nunez, and for inviting your students. He is saying, or actually asking, what are the most common concerns during residency year? And by the way, great talk, very well oriented for future neurosurgeons. Congratulations.
Oh, thank you. Yeah, neurosurgery is just residency in general. I think the most important thing is, right, show up, okay? So show up on time, and and um, and just be patient with everything, because a lot of it, you learn by experience, you learn by doing. Um, yes, you do have to read, but you learn by repetition. So I think you have to keep your eyes and ears open, um, and and just be there, right? Show up early, leave late, and and try to take everything in as much as possible. We in neurosurgery, we don't like people talking too much. We don't like a million questions. We like you present, paying attention, and taking it in. And if we see that you're paying attention, then we let you do more. At some point you're standing there, and then we just hand you the instruments, and we let you try your hand at it. So just be present.
Great. In your opinion, what is the role of personal statements, and what clues can you give us during the interview?
Personal statements are it's important. I think it's right. Your USMLE scores are probably the most important, because that's what gets you in the door, right? That's what gets you the interview, because there is that the programs have a threshold. So then once you get past that threshold, then we look at your your um, your recommendation letters. And a lot of these recommendation letters have a language to them that you have to learn to discern. Like, this person would be excellent uh, for your program, or this person would be wonderful in our program. So in other words, like we don't want him, but I think he would do well over there, or we really want this guy. So, and that's sort of a behind the scenes look. The personal statement's really important because, right, there needs to be empathy and there needs to be understanding. And so I think if your personal statement conveys a true desire to to do the job to the highest level, and do it with empathy and do it with concern, and really be the best at what you're going to do, then I think that it's going to rank high when they start looking at interviews.
Great. Brenda Hernandez has a question, and she wonders, what are the tips that you can actually give our students to avoid burnout syndrome?
That's really tough. So they didn't start talking about physician burnout until the later years in my residency. And so, you have to have a personal life, right? And it's hard sometimes, because even when you're not working, you're exhausted. And my wife still still reminds me of the times that I would fall asleep at the dinner table at a restaurant, or the time that she fed me pizza and I don't remember eating it. So it's really difficult, but you have to try to find time for yourself, whether it's putting a pull-up bar at your house, whether it's doing some yoga, whether it's reading a book. And it's as easy as, if you're at the hospital and you're killing some time in between cases or whatever, bring out your phone and read a book, or put a pull-up bar in the residency call room or something like that. Um, but trying to find time for yourself, it's difficult, but it's not impossible.
Maria Musmani has a more specific question for surgery. Are there any specific postoperative precautions that we should share with the patients that we need to keep in mind, especially those that are elderly?
Yeah, so before surgery, we try to make sure that patients have pretty good bone density. So most patients should be on calcium, on vitamin D, things like that. And if they have a lumbar fusion, then they should continue on calcium with vitamin D after surgery. Um, and then it's important to maintain a certain level of activity. And there's lots of yoga for the elderly. There's lots of places where people can go walk. I mean, the mall is a phenomenal place to walk because it's air conditioned, or you can go, Baptist, for example, has this lovely path in front of the hospital where you can go and walk and do exercise. So staying active is the most important thing that I would recommend them.
Great. Wenceslao, he's wondering, thanks for the opportunity. He says, how much research is done during residency? Is it through the whole residency or strictly during a period of time? And what is the role of the resident on the whole department research work?
It depends. So some places do a lot of research, right? So if you were at the Barrow Neurological Institute, you would be publishing a ton of papers because they really want that. When I was a resident, I I I did very little research. I did more like case presentations and things like that. So you can do as much or as little research as you want. There's some people that are just are really good at writing papers and doing research and really enjoy it. And then others who it's not their thing. They'd rather do a bunch of cases instead of that. So I think with most places you have to do some, right? But then it's to the point where you're really allowed to do as much or as little as you want. And they encourage you to do research. They provide you the resources. They provide you the labs. If you need a bunch of cadaver heads, they provide that for you. So it's all set up for you to succeed.
Extremely important. Request those cadaver heads.
Exactly.
Ariana Alcaraz is from Universidad Católica de Santiago de Guayaquil from Ecuador. And she is wondering, what is the hardest part of being a resident on a country where you don't belong? I guess you're not from. Is the economic factor really important? I would like to apply for gastroenterology. Thanks.
You know what? You make very little money as a resident. But when you're a medical student, you don't make any money. So when you make, I don't know, $40,000 a year, it's like, wow, I'm making something, So you're not going to make much money as a resident or as a fellow. But if you are a hard worker and you speak English, then certainly in the U.S., they'll make room for you, and it's not. I don't feel that foreign medical graduates that get in are discriminated against. I think they're given the same opportunity. Just it's harder as a foreign medical grad, but there's one of my colleagues. He's Brazilian, and he's a neurosurgeon who's now practicing in San Diego, California. And I think he scored the highest USMLE score in Brazil, and he blew my score out of the water by like 30 points. And he, did great in residency, and now he's doing great in San Diego, and he's extremely happy. And so I think if you put your mind to it and you give it your best effort, then there's no reason why you can't make it happen.
Ariana, there you go. The sky is the limit, so go for it. Gastroenterology, it is for you. Doctor, in some cases where patients are complaining of sciaticas and you already have determined, not only by imaging, but the symptomatology, that this patient will require a surgery either now or eventually. However, some neurosurgeons decide to, perhaps you need to wait, and we do pain management instead for quite some time. And then the question is, when is it appropriate to actually square things for the patient and say, listen, you can get pain management care. However, your quality of life perhaps is not going to be necessarily the same. Is that some kind of conversation that you typically have with the patients?
Yeah, so we know from the literature that 85% of people with sciatica, say, will get better on their own. within 6 weeks to 3 months with conservative treatment, right? So physical therapy, um, anti-inflammatory medications. So they could be NSAIDs orally. It can be a course of methylprednisolone orally. It can be an epidural steroid injection. Um, you know, and so I think so somebody who has discomfort, right? They're not miserable, right? They have discomfort. Then I think it's if they allow you to try to exhaust conservative treatment, then I think it's reasonable to give them 6 weeks at least to try and see if they can get through this without surgery. If I see someone who is just miserable, right? They're writhing in pain. There's no way that they can wait 6 weeks. There's no way they can do physical therapy. They need a solution now. Then I recommend they have surgery sooner than later. You know, and anytime you're going to have a surgery, right? You have to be all in because surgery, it hurts, and you have to allow yourself a certain period for recovery, whether that be 2 weeks or 6 weeks. You know, it's hard to predict. So if you're going to have spine surgery, I think you have to be 100% committed that, listen, this is going to hurt. I'm going to be miserable for a week. By, after a week, I'll be okay. And then I'm ready. So that is like the standard counseling that I give patients.
Great. Now, obviously, you are the lead in minimally invasive spine surgery. But at any given point, obviously, you can consider doing the traditional approach or typical approaches that we know and in the rest of the world that still take place because of no resources or no robots, etc. Do you encounter those kind of scenarios in which you have to go through the traditional way of performing a neurosurgery instead of the robotic procedure?
Oh, of course. So I prefer to do, I prefer minimally invasive spine surgery because it results in less tissue damage, speedier recovery. But, sometimes due to the patient's anatomy, due to, their medical history, say they've had a colostomy before, say they've received pelvic radiation, and you can't go in from the abdomen because it's not safe. Then if safety is a concern, then we always are able to fall back on traditional approaches. I mean, what's with spine surgery, right? Most everybody can do the traditional spinal procedures, whereas less people are equipped to do the minimally invasive. So we always have that as a plan B.
Valeria Aguilar asks and states, Dr. Gomez, excellent talk. Thank you. My question is, what would be the recommendations to prevent degenerative disc disease in young people?
Oh man, if we figured that out, we would have the Nobel Prize.
And you would have no work.
Exactly. No, I read somewhere that 70% of people, so 70% of MRIs by the age of 35 already start to show degenerative disc disease. Mm-hmm. So it's like saying that you have gray hair and wrinkles on the inside. So unfortunately, no, there's no way to prevent it, but I do think that if you remain active, right? So with a normal BMI, if you remain active with good mobility, so play sports, exercise, lift weights, yoga, Pilates, that sort of stuff, then I think that you can sort of protect yourself from having spine injuries.
Great. Well, Dr. Gomez, I promised everyone that this was going to be a different talk, and indeed it was. So grateful that you toned it down this time. It's amazing. There is Stefania Leon is saying, Dr. Gomez, I like your talk. I wanted you to know which is your next career goal. I wanted to know which one is your next career goal, or do you feel that you have achieved your goal?
No, I've not achieved my goal yet. Once you feel like you've achieved your goal, you sort of quit, and then you don't really go anywhere. So So right now I feel like I'm at the forefront of modern spine surgery, and I'm curious to see where that's going to go. Um, I feel like in medicine I've taken, and I've not given back enough. So ideally in the next 5 to 10 years, it would really be nice for us to have a fellowship program for minimally invasive and complex spine surgery here at Baptist Health South Florida. And so I think that would be my next goal, to be in a teaching position where I can form and mold future spine surgeons, um, to continue advancing the art and advancing the science.
Pilar Rasuri just asked in Spanish, en el caso de una anterolestesis, ¿cuál es el mejor tratamiento?
Do you want it in English or Spanish?
In
Or
English.
both? Okay. So it depends, right? I try to treat everything, from the front or from the, from the abdominal side of the spine. So at L5S1, we typically use an anterior approach called an anterior lumbar interbody fusion, which is an excellent surgery. The patients recover quickly. The disadvantage is that you need a surgeon to provide the access to that part of the spine. But anything above that, so at L4, L5, L3, L4, L2, L3, then you can use a minimally invasive lateral approach, which I do the exposure myself, and it's a it's a nice procedure. Patients get good relief for their pain, and so I think that taking an anterior or a lateral approach is the best way to do it, depending on the level.
You've heard the man, and any of you at any given point, if you ever need a neurosurgeon, this is the guy for you to visit. Dr. Gomez, thank you once again. It is the top of the hour. We want to be considerate to you. We know you have a long day tomorrow as well. So we're going to go ahead and stop. Otherwise, these guys will keep you on forever. So on behalf of Baptist Health International, obviously, thank you, Dr. Gomez, once again, for this incredible presentation, and to all of you for participating and for your attendance. If you have any additional questions about Dr. Gomez's presentation, please feel free to email it to us at internationalbaptisthealth.net. We'll make sure to actually forward those questions to him so he could respond back to you. We look forward to seeing you at our next monthly medical lecture, which is scheduled for Wednesday, December 2nd, 2020. Thank you again, and have a great afternoon, and please be safe. Thank you, Dr. Gomez.
Thank you very much. It's my pleasure.